So one of the first things that I did was jump right into a vestibular examination with Catherine because she's so extremely fatigued and tired. I can tell right from the history that she's not going to have much endurance. So the most important information I needed to figure out is what's causing her dizziness. So what I'm doing here is that I have her on what are called V&G diagnostic equipment, and they're just infrared cameras to look at her pupils. Now, you could do this yourself with just a pin light, but I'm just looking to see if your pupils are responding to light and if her eyes dilate in darkness and constrict in a lit room. So you're going to click the lights on and off. Now, the key thing to look at is, first of all, does she have a pupil response? One of the things that you always have to consider when you start to see neuroinflammatory issues is if the neuroinflammatory issues in the optic tracts. So when people have optic tract inflammation, like optic neuritis for multiple sclerosis, or even patterns of optic nerve inflammation that you may see with various neuroinflammatory responses, you're going to see that pupils not respond, and the patient may even have differences in color between looking at an image that's red with one eye and then look at the other eye and it might be pink or something like that. So with her, we're seeing her pupils respond properly. We're seeing that they're dilating properly. And now with people that have dysautonomia, you might see pupil constriction and dilation that's totally abnormal, where the pupils may just be constricting and dilating on their own, whether it's in a lit room or a dark room. So from this initial part of the examination, I can really see that she does not have any signs of optic neuritis, and that her pupils are responding properly, and she doesn't have any significant patterns of dysautonomia that are at least impacting her pupils at this point. I'm over here. I need to check to see if you have something called nystagmus. What I have to do is I have to close these so you don't see anything, okay?
Okay.
I'm turning these on and off too. Okay, so what we're doing now is we're just checking to see and differentiate between central and peripheral vestibulopathy. So in darkness, usually what we see is nystagmus. Kathy, you don't have any nystagmus. We're just taking a look at your eyes here. But we'll see beating of the eyes. So right now we know it's not a peripheral vestibulopathy because we're not seeing any type of abnormal nystagmus or movement. Do you feel any movement at all?
What do you mean movement?
Do you feel like you're spinning to one side or
No.
anything like that? You feel pretty stable where you are? Okay, perfect. Can you look all the way to the left? Okay, and look all the way to the right. And look up. Look down. Look straight. And look to the right again. Okay, and straight again. Perfect. So evaluation of nystagmus in darkness, or evaluation of nystagmus with Frenzel goggles, is going to really help you figure out what's going on when someone they have dizziness. So one of the concepts you have to understand is that your brain is constantly figuring out where you are in space by input from your visual system, input from your vestibular system, and input from your proprioceptors in your feet and throughout your body. And then it integrates that information, and then it lets you know where you are in relation to the environment. So one of the things that is done with a normal vestibular type of exam is you have a person put on either the goggles I'm using, which allows them to not see through them, and then have infrared cameras that are picking up their eye movements. Or you can get very inexpensive equipment called Frenzel goggles, and the Frenzel goggles are goggles that they put on where there's a hazy tint to the goggles, so you can see their eyes, but the patient can't really fixate on a target. It's too blurry. And that takes away visual input. So that really allows the vestibular pathways to express themselves. Now, when people have peripheral vestibular disorders, they can usually compensate for their eyes not showing nystagmus because their visual inputs can get to the brain and the brain can suppress them. But once that visual input is blocked, either by Frenzel hazy goggles or by putting them in darkness, which I'm doing here with the infrared cameras, you'll see if the nystagmus will show up. And if someone has a very acute vestibular neuritis, where, like, for example, a virus is infecting the vestibular nerve, then you'll see the eyes bounce all over the place, and you have this so-called pattern of nystagmus. With her, we don't really see that, so we know she doesn't have an acute vestibular neuritis that's happening. And usually when those happen, there's very severe symptoms of dizziness and nausea and so forth. But sometimes they're a little bit subtle and you can see them, but at this point we don't see that with her. The other thing that you'll see me do in this part of the exam is I have her look up, look down, look to the right, to the left, and I'm looking for what's called gaze-evoked nystagmus. And she has gaze-evoked nystagmus. So if you look, when she looks to the right, especially when she looks to the right with full range of motion, you'll see right away that the eyes start to develop nystagmus. There's a little fast phase and a quick phase. And she has what's called a right beat nystagmus when she looks to the right. So you'll see the eyes move quickly to the right and then back to the left, and then quickly to the right and then back to the left, and it just kind of bounces around like that. And it's very subtle. If you're not used to looking at nystagmus, you may have to watch the video a few times. But once you start looking at these patterns and get some experience, you can really see them very clearly. So she has a right beat nystagmus. Now, a right beat nystagmus means that the right vestibular pathways, the pathways from the vestibular nerve to the vestibular cerebellum, are not working well. And that causes the left vestibular system to push the eyes over to the right side in a slow phase, and then the frontal eye field see that their eyes are out of place, and they push the eyes quickly back to the right, and this is what you'll see with her. So she's got a right beat nystagmus, and now we know that her right vestibular pathways into the right cerebellum may not be working very well. Now what I'm going to do is I'm going to have you do a test called a head shake test, okay? So you're just going to turn your head back and forth like 10 times. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and just look straight ahead. You feel movement?
Not really.
Okay, just keep your eyes straight ahead. So we have some left beat nystagmus. The stuff we're seeing on you, Catherine, I'll show you in the video when we're done. I know you can't see it. Okay. Well, let me do that one more time. Go ahead and shake your head again, 10 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and then head straight, eyes open. And the repeat testing shows that it stabilized more. The first time you did that head shake, did you feel any sense of movement after we stopped, like you were still moving?
Not really.
Okay. So there's different ways to look at dizziness. The most severe types of dizziness, as soon as you have them look in your direction, you'll just see their eyes bouncing all over the place. That happens with very acute vestibular neuritis and severe forms of dizziness and brain injury. The next degree of patterns of nystagmus you really don't see unless you put them in darkness or provoke them by looking at gaze, or provoke them with something called like a head shake test, which is what we did here. So with the head shake test, what you're doing is you're having the patient move their head back and forth, left and right, left and right, left and right, left and right. And that's activating the left vestibular system when they move their head to the left, and then activating the right vestibular system when they look to the right, and you go back and forth, back and forth, and back and forth. Now, if one side is not working as well, if there's lack of integration between these two sides, when you stop the head shake test, you'll see some nystagmus. So with Catherine, we see nystagmus the very first second as soon as she stops the head shake test. So if you don't see that, make sure you replay the video, and as soon as the head shake test stops, immediately look at the eyes, and you'll see that the eyes start bouncing to the left this time. They're going to the left side. Now, if you look at the image, you'll see on the eyes, one's labeled left, one's labeled right. The one on your right side is actually the left eye. The one on your left eye is actually the right eye. So you see the quick phase of the nystagmus going to the left. So now we're seeing a left beat nystagmus with head shake test and a right beat nystagmus with gaze to the right. So this is letting us know that this is most likely not just vestibular neuritis, but the cerebellum itself is in trouble, that this is really central based. And with central based, meaning brain based, not vestibular nerve itself, with central based disorders, you'll get a very clean, pure horizontal or pure vertical nystagmus, which is what we're seeing here. Now I'm going to do the same test, but I'm going to turn you now in the chair, okay? So I'm going to move you to left and right. So be a little bit more aggressive. So I'm just swiveling you left and right here for another 5 or 6 seconds. And those are vestibulocular reflexes, those are intact. So with the chair rotation test, what you basically do is you have the patient sit in a chair where their legs are no longer touching the ground, so the chair is high enough where the legs hang, and then you just move the chair back and forth, back and forth, and back and forth, and then this activates the left and right vestibular system, just like the head shake test. And with her, what we're seeing is that the first second, right after we stop, she again goes back to a right beat nystagmus. So this really indicates, again, a central-based cerebellar type pattern for her dizziness and her eye movements. And we're seeing this bilaterally on both sides, which means that it's not just the infection of the vestibular nerve that's causing that. This is really a brain-related mechanism, and this may be associated with cerebellar disease from autoimmunity, from cerebellar autoantibody reactions, or from TPO antibodies that are cross-reacting, or even potentially from microvascular disease that is in the early stages. I'm going to have you take some deep breaths in and out like you're hyperventilating, like that for 10 seconds. Keep going, keep going. Okay, and relax and open your eyes. So the hyperventilation test is a very interesting test. What you basically do is you have the patient hyperventilate, and this creates a state of hypoxia, and sometimes this is one of the only ways to really see nystagmus come out. Now, unfortunately, the camera that was taping the screen, the battery died right in the middle of this test, so you can't really see the eye movements. But what was happening was that there was a downbeat movement, so the eyes are moving up slow and then coming back quickly downward. And downbeat nystagmus is characteristic of cerebellar dysfunction, cerebellar disease. They call that infratentorial types of patterns, meaning in the tentorium, below the tentorium. This is where we have cerebellum and brainstem patterns. So again, this confirms that there's cerebellar type patterns. So we have, right beat nystagmus with the right gaze. We have head shaking test that causes a left beat nystagmus. We have hyperventilation, which causes downbeat. So this lets us know Catherine's cerebellum is really in bad shape. Like, you should never really see nystagmus with people that have healthy brain function. It's only when you get some significant degree of compromise that you'll start to see these patterns. But these are somewhat expected because she has chronic, ongoing, steady dizziness all throughout the day, and these are really more likely brain-based than just the vestibular inflammation itself. Okay, what I'm going to do is I'm going to check your reflexes. We did them a little bit when you're moving in the chair. Then I'm going to go back and forth. Okay, so let's get a good image here. I'm going to go back and forth. And those look pretty good. Okay. We're going to have you stick your finger out. Stare right where your nails and skin come together, okay? Keep your eye right focused on that. There's a couple, looking to see if all that VOR cancellation takes place. You see there's still some bouncy movements when we put her in the chair that way.
Okay, great. Go ahead and relax. So that's a positive vestibulocular reflex cancellation test. She wasn't able to stop the vestibulocular reflexes when she was fixated on a target. It's going to be important for us to figure out how to help her balance issues.
So with the vestibular ocular cancellation reflex, basically what happens is once we know that a person has intact vestibular reflexes, and you saw when I was moving her in her chair back and forth previously, her eyes would bounce back and forth really quickly, and those are normal responses and reflexes. Now, one of the tests that you can do, which is this vestibulocular cancellation reflex, you have a person stare right at a target. So I had her stare at her thumb and then move her back and forth in the chair. When you do that, the eyes should not move at all. The eyes should be totally fixated on the target. And if they slip, and you see with her there's little bounces all over the place, that is a positive test. And this is very specific to an area of the cerebellum called the Purkinje cells. The Purkinje cells are pathways from the cerebellum cortex down to the deep cerebellar nuclei, and these are inhibitory pathways. These are the most sensitive cells to hypoxia, so they're very common with microvascular disease. These are also cells that studies have shown have molecular mimicry and cross-reactivity to gluten. Gluten proteins cross-react with these Purkinje cells. And this is a common area of injury with autoimmunity and even potentially TPO autoantibodies. So now we know that she's got the inability to dampen her vestibular reflexes and responses from this test. And this is very important because we're going to give her some visual fixation exercises to rebuild this area of her brain, and that should make a big difference in her dizziness patterns. Here you can see that I'm looking in her ears, and one of the things that you really want to have is you really want to have a good tympanoscope so you can really look at the eardrum. So I really wanted to see if there's any injury to her eardrum. Sometimes you have fistulas, sometimes you have viral infections that damage and put holes into the tympanic membrane, and then in those cases just pressure and movement and atmosphere changes can really flare up vestibular issues. Now, her eardrum was totally fine, and there was no issues or patterns associated with anything happening with the anatomy of the tympanic membrane that may be contributing to her patterns of dizziness.
Just going to check your eardrum pressure. Pull this up here. Great. Do it on the side. Now when you hear a noise, Catherine, you're going to push this. Okay. Get you a little closer here.
I want to push it, but I'm not sure.
Okay, if you're not sure, don't push it. Don't
Okay.
push it.
So with any normal vestibular evaluation or a very thorough vestibular evaluation, you should definitely do a tympanometry and audiometric examination to assess intactness of the eardrum and also to see if there's any types of hearing loss. So with people that have autoimmune disease, it's also very possible for them to have Meniere's disease. And with Meniere's disease is autoimmunity against Meissner's membrane, and this can lead to changes of chemical discharge between perilymph and endolymph that then causes dizziness and vertigo. Now, with that pattern, you actually have hearing loss and you have tinnitus. She doesn't have those patterns. So her hearing is intact, and she has, again, tympanic membranes that are okay. So this just rules out different types of differential diagnosis for dizziness. And it's still showing that more than likely that her pattern of dizziness is associated with cerebellar disease.
Keep your eyes open and just be as stable as you can. Okay, perfect. Now put one foot in front of the other.
You mean like walk?
Yeah, I'll show you like this. Yeah, like just like that. And just stay where you are. It's a little difficult, huh?
Yeah, it is.
Okay. Does that make you nauseous at all?
Not really.
Okay. Okay. Go ahead and bring your foot back. And bring your other foot forward. And just stay right there, eyes open. You already just feel it, huh? Okay. Whoa. Okay. You're good? Bring
Okay.
your feet together. Does that cause anxiety for your heart rate to go up? You feel?
I don't know, does it? Is that what
I'm
happens?
asking you. Do you feel something?
I don't really feel it.
Okay, good.
I mean, I feel a little more jittery, not jittery, but...
Okay, perfect. Go ahead and close your eyes now. And I got you. You're not gonna fall, okay? My hands are right next to you. Perfect. Okay. Now go ahead and just, there you go. Okay, let's get you stable.
Yeah, right. Here, wait a minute. Let me do it. Let me do it.
Okay.
Good.
Okay, I got my hands. Are you good?
No.
Okay.
I can't.
Let's try the other side. Okay, great. Just relax.
Okay.
What I want to do is with your eyes open, just try one foot at a time, just standing. So
Oh,
let's
like
say,
pick
stand
it-
on your right foot only.
Like a tree pose.
Yeah.
On my right foot.
Yeah. There you go. Try the left. I just want to compare them. Perfect. Okay. So what I want, then once I feel easier for you to do, you can bring your feet apart.
I'm not sure.
Okay, Deadly.
I'm not sure.
Go ahead and try.
I think the left one is.
Yeah, I think so too. Okay.
So here we are doing tests of stability, Romberg's test, tandem Romberg's, where they put one foot in front of the other, and then a 1 foot Romberg's test. Basically, she has a positive test for each one of these tests for stability, meaning that she has significant instability and titubations. So you can see as soon as she gets in a position to keep herself stable, that her whole trunk and her whole body and her legs and her foot are moving all over the place. Those are called titubations. And, I have my arms right around her shoulders, and there's no doubt that if I wasn't there keeping her from falling, that she would basically fall to one side within the first second of doing the test. So these let us know that her midline cerebellum is off. If you look at the brain region localization form, you can see that she has all the symptoms of spinal cerebellum and vestibular cerebellum. Those are the midline areas that are involved, and they are absolutely involved. She has significant degrees of instability.
I want you to stay here. I'm going to give you a little pull. Okay?
Okay.
And you're going to just catch your own steps. I'll be behind you so you don't fall.
Okay.
Close your eyes.
Whoa.
Okay. Are you alright?
Mm-hmm. Are you?
Okay.
Okay.
We're going to do it one more time.
Okay.
Okay. Wow, that's definitely a positive test. Okay. Very good.
So with a pull test, what you're trying to do is you have the patient get stable, close their eyes, and then you give them a little tug, and they are supposed to be able to stop themselves from falling backwards with less than 3 steps. Now with her, she just falls. And then I just want to make sure it's not a fluke, so we do it again, and it's pretty clear that she doesn't have proper postural reflex, which means she's at major risk for a fall. And, once you get above age 55, one of the top 5 causes of death is death from complications of a fall. So we had some high-risk activity here. Now, the pool test is typically done as a screen for Parkinsonism. And with Parkinsonism, people lose their postural reflexes neurologically. And when you give them a little pull, they really can't keep stable, and they bounce all over the place with multiple steps to try to get themselves stable with at least more than 3 steps. With this isn't a pull test confirming that she has one of the key factors associated with Parkinsonism. It's just that she's completely unstable, and these are really stressing out what are called otolithics that translate forward and back, and her translation forward and back through these otoliths are also off, and that further suggests that it's not just that her vestibular nerve itself, that these are really involved with integration of that midline cerebellum.
Good. And then
Turn, do it again.
okay. We're gonna do something called double tasking. So when you walk this time, you're gonna do the alphabet out loud.
Okay.
But every other letter. A, C. Okay. Doesn't matter if you get it right. We just wanna see. But you have to keep the motion.
Okay. A, D, F, H, J, L, N, P, R, T, V, X, Y, Z.
Perfect.
So when we do a gait analysis and check her ambulation, you can see that Catherine is completely unstable. You can see her arms are out to the side, and she's walking as if she's walking on something very, very slippery, but she's just walking on carpet. So this strongly suggests that her balance and stability pathways are off. It's very clear when she walks. Now, the other part of the test is to have her walk while she's doing double tasking, and double tasking activates the frontal cortex. And for a lot of people, a lot of times their vestibular patterns or their gait abnormalities will become more clear when you ask them to double task. But in some cases, they actually get better. And you can see with Catherine, when she actually double tasks and activates that frontal lobe, that her arms start to swing. They're no longer out trying to keep her stable. And, the pathways to the cerebellum, there's what are called frontal pontine projections, and the frontal lobe does have some stimulating effects on the cerebellum. So we know her frontal lobe is intact, and it's helping her with her gait when she double tasks. But ultimately, she has some significant degree of postural instability during ambulation.
Put your hand out like this, and then go back and forth as fast as you can. It's pretty good. And then your elbows in, elbows all the way in. Do the same thing. Perfect. Okay, great.
So the repeated supination-pronation test is really a test that evaluates what's called the lateral cerebellum or the cerebrocerebellum. And the cerebellum is involved with working with the frontal cortex to calibrate movement to be smooth. And with her, when she does this repeated supination-pronation, you see that she is doing it perfectly. That she's not having any pauses, that the movements are smooth, and they're pretty much equal between left and right side. So this lets us know that her lateral cerebellum is healthy, and the connections between her frontal lobe and cerebellum are efficient. And just like when she was double tasking, her balance became better. So those are the clinical findings with the supination-pronation test.
And then I want you to take your hands like this, and then go like this as fast as you can. All the way open, all the way close. Fast, 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 fast.
With the repeated finger to thumb test, you're basically looking for speed. You're looking for something called hypokinesia, if there's any slowness of movement. It's one of the first things you start to see when the basal ganglia direct pathways is involved. You'll see that with early patterns of Parkinsonism. So her repeated finger to thumb speed and dexterity is intact. And those are letting us know that her frontal motor cortex and her basic ganglia direct pathway are healthy.
Go like this as fast as you can with the fingers.
Repeated finger flexion or piano playing is just the same as the repeated finger to thumb testing. You're just looking for dexterity and speed and smoothness of movement. And with her, these functions are healthy and intact. So here you can see Catherine is doing visual fixation exercises. In visual fixation exercises, one of the things you always want to do if you see someone has inability to cancel out their vestibulocular reflexes. So remember when we had Catherine in a chair and moved her back and forth and had to stare at her thumb, her eyes kept slipping. So the way you rehabilitate that, and the way you can rehabilitate many people that have balance and dizziness issues, is to do what are called visual fixation exercises. So when you fixate on a target, that activates areas of the brain in the frontal eye fields to activate the cerebellar Purkinje pathways, and those types of stimulation over a period of time and repetition can develop plasticity and connectivity. So with her, I'm having her do this to see if it really has any change in her outcome and her balance and her stability. And I always like to see what is wrong with the brain first, and then see if I can find a way to activate that. That'll be one of the therapies that we'll do for vestibular rehabilitation. Now, again, if you don't do vestibular rehabilitation, you can always refer out to a physical therapist that do neuro rehab, or people that do functional neurology in the chiropractic profession that are trained to do these things. But it's something that's important for her case, because we got to get her stable to get her out of her sympathetic patterns and her dysautonomia.
Do you feel any difference in stability?
You know, I do feel a little bit better.
Good.
I do! No, I do.
Yeah.
Yeah.
Good. You look a lot better.
So this is evaluation of her gait immediately after she did those visual fixation exercises. And you can see, even though she's not completely stable, that her balance has completely changed just from 10-15 seconds of doing those visual fixation exercises. Her arms are not to the side, like she's walking on something very slippery. She still has some issues with how she turns and moves, but there's a big difference in her gait and ambulation after the exercise, and she was able to even notice the difference herself, and she was pretty shocked by that. So this just confirms that that's one of the things we're going to do to help stabilize her. And once we can get her stable, then we can get her out of her dysautonomia and her sympathetic drive, all the things that are not allowing her to sleep, and all the things that are impacting her immune function by constantly firing that sympathetic stress response pathway.
So after the you were noticing the dryness on both eyes, and sometimes excess tearing.
Yes.
Okay. So there's the facial nerve that innervates the muscles in your face, and then that goes into an autonomic center, which is involved with tearing as well. It's like the autonomic area. So it can make you fire more, and you get tearing, and then fire less, and you get dry eyes. But you do have to use drops since then. Okay. Right, now I want to check your muscle tone. So this is just your face totally relaxed right now, right? Okay. Then we can take a look at the muscle tone here and here. And go ahead and wrinkle your forehead, like all the way up, like wrinkle your eyelid. There you go. That's fine. And there you go. You can see. Go ahead and do it again. There you go. Smooth. There's not too much movement here.
I get Botox in here for the muscle. And
Just to get rid of the
relax. Yeah.
Yeah. It gets really spastic on you.
Oh yeah.
And how often do you have to do Botox?
Every 4 months. About every 4 months.
Okay. Go ahead and do it again.
What am I doing? Up?
Yep.
And down?
Okay. Then blow your cheeks out. Best you can. Okay. And then you see, like, you have to hold your mouth in place there so you can do the best you can. And then you can see the muscle movement there. And no muscle movement there. Okay. And open your eyes as wide as you can. That's cranial nerve 3. Close your eyes tight. Now I'm going to try to open your eyes here. There we go. And open your eyes here. Difference there. Okay.
So when you first look at visual inspection of her face, it actually looks like the left side may have the facial paresis, because you see that nasolabial fold is reduced on the left side, but it's increased on the right side. And when we actually test her motor function, you can see that right facial musculature is not working. So what this tells us is that this viral infection not only injured the peripheral nerve, but it actually got into the brainstem and impacted the motor facial nuclei. So it's really more of an upper motor neuron pattern, not just a lower motor neuron pattern. So remember, with upper motor neuron disease, you get spasticity. So you actually, what you're seeing with her is you're seeing weakness with spasticity. Just like when someone has a stroke, you see their arm spastic, but when you actually test the strength, it's really weak. So this viral infection clearly has gone into the brainstem and impacted the cranial motor nuclei to the point where she has severe pain and spasticity, and the way she gets some relief from that is she gets some Botox. So this lets us know that there's some central nervous system damage in addition to peripheral nervous system damage from her viral infection. Now, classical Ramsay Hunt, you really just get peripheral vestibular patterns that then heal on their own. But in this case, when we see weakness with spasticity, we know that brainstem nuclei was involved. Now, also, you can see when we actually test motor strength function that it's her forehead and the muscles in her lower face, and that lets us know that that's the peripheral nerve that's involved. Usually when it's just the nuclei, you only get weakness in the lower facial muscles because the upper is bilaterally innervated. But when the actual facial nerve is injured, then you get weakness in the forehead, upper and lower face. So she has injury to both her peripheral and peripheral facial nerve 7 and her central facial nerve nuclei because of the distribution of her weakness and the spastic tone pattern that you're seeing in those facial muscles.
Just going to do a quick reflex. I'm just going to touch your eye with this tissue, okay? Go here.
No, you're not. You're not going to really touch it. No, you're not going to touch inside my eye. You're not going to touch the inside of my eye.
Just your eyeball. It won't work.
I don't like those tests in the eye doctors.
That's
All
it.
right, go ahead. Do
That's
it.
it. We did it.
You did it? You didn't really touch my eyeball.
I
You
did.
touched the
It's on
eyelash.
video. I'll show you. Okay. Now you're looking for a blink response, so that's perfect.
With the corneal reflex test, you're really testing trigeminal sensory perception over the eyeball and how it reflexively activates the blinking response through cranial nerve 7. So it's 5 sensory and 7 motor. And this is just checking the integrity of the lateral portions of the upper brainstem, and she's intact with those.
Now, I want you to tell me how this feels left to right.
It feels like you just put a tissue over it. I mean, I can feel it. I can feel that, and that, and that.
And these are all trigeminal, different than 7. This is a pinwheel. Okay, it's clean. No one's used it.
Okay.
Feel that
I do.
prickliness? Okay. So when I do this on your face, you
Okay.
can tell me if it feels the same or different to you.
All
Okay.
right. Same. Same. Same.
Great. So these are your different cranial nerve. The cranial nerve 5 called trigeminal, and then that's different than the pain you're having. The pain you're having is that sharp, like burning type pain, right? That's like neuropathic pain. How often do you get that sharp pain there?
Not a whole lot.
Okay.
See, right now I have pain back in here, and I don't know, but I just went to the dentist, so I don't know I don't know what it is.
You're feeling a pain here.
Mm-hmm.
Now,
Because you just did that? No.
no. But you were saying you're having some sharp pains in your face.
Are they sharp? It's like I get kind of a headache, and then I kind of get a pain, but it's not like a sharp pain, no.
Is it always on your right side?
Yes,
Okay.
it's always right here. And it's just started to happen in the last few weeks.
And how many episodes of like pain sensation get a day?
Sometimes I don't get any at any day, and then other days I might get maybe 3 or 4, something like that.
Okay, and are those days associated with more or less pain
Pain where?
in your face, like those episodes? Like, I mean, I'm sorry, the episodes you're having, are they related to like your sleep, your energy levels?
I haven't really, I don't know.
Okay,
I
so can you do me a favor?
Yeah.
If you have like a really bad sleep day, right?
Okay.
And your energy's really low.
Oh, you know what? This last week I've had really bad sleep days, and I have had that more.
Okay.
Yes.
So then, moving forward, in addition to remember your connection between your stability of your balance and sleep,
Okay.
I want you to let me know about your level of quality of sleep and those episodes of pain you're having on your right side of your face. Okay.
Oh boy, I can
I'll
just
remember all this for
lay
you.
down right now. That does.
You want it?
That just
Take a
see?
break. Take a break.
Oh,
So in this part of the exam, we're using the pinwheel to then check V1, V2, and V3. These are from the trigeminal nerve. Now, if you remember with Ramsay-Hunt syndrome, the viral infection infiltrates cranial nerve 7, which is motor. But within the motor fiber, there are nerves that can be injured that then cause neuropathic pain. Now, with some people that have injury to cranial nerve 7, their neuropathic pain gets so sensitive that even though you're checking sensory over trigeminal 5 on the face, if the muscles, the nerves within the muscles are severely inflamed and injured, then you can get hyperalgesia pattern where a person has a lot of pain when you stroke their skin, and you can even get allodynia, or the just touching the skin with a tissue or napkin can really cause a lot of pain. But she doesn't have any of those, but she does have neuropathic pain in the nerve fibers of cranial nerve 7, not the trigeminal sensory pathways, but in the nerve fibers in cranial nerve 7. So this is just started more recently, and this is start to happen when mitochondria impairments start to take place, and basically those neurons become unhealthy over time, and this can then lead to central pain patterns that could really make her miserable all the time. So this is something we want to make sure we ask about on a regular basis, because her quality of life can dramatically go down if she starts to have cranial nerve 7 neuropathic pain and then centralized pain from that.
you want me to tell you if it's cold or
Why
hot?
don't you tell me if it's the same first?
Okay.
So tell me if this is the same as this.
Yes.
And is this the same as this?
Yes.
And is that the same as that?
Yes.
Great. Now just tell me if it's cold or hot, okay?
Cold. Warm.
Warm. Yeah.
Warm. Warm. Cold. Cold. No, that's cold.
Perfect.
That's warm.
So temperature, perception, sensation of V1, V2, V3 are intact. We would expect to see that with her current pattern.
Let's put your arms down like this first. Yeah, there you go.
Same. Same. Same.
So just a quick screen of pinwheel examination on her upper and lower extremities. You don't have to go through and check every single dermatome and peripheral sensory distribution one by one unless you really suspect her history. But just a general screen to see if there's any differences. Now, if you remember from the brain region localization form, she had symptoms of bumping into things, and she had symptoms of parietal lobe dysfunction. Now, those may just be related to the vestibular issues, so when we go through and check pinprick and temperature sensation and 2-point discrimination and vibration sense in her extremities, those are just evaluating her peripheral nerves, but those are evaluating the contralateral parietal lobe. So we're really interested based on the symptoms she had on the brain region localization form to see if her proprioception, temperature sensation, pinprick sensation of her extremities is different from one side to the other, to evaluate not just her peripheral sensory system but her parietal lobe.
Which one's cold? This is number 1 and this is number 2. Which one is colder?
The first one.
This is 1 and that's 2.
The first one. No, the second one was colder.
Okay. Here's 1 and here's 2.
First one.
And here's 1. Here's 2.
The second one.
Okay, switch these over. Here's 1. Here's 2.
The first one.
Here's 1. Here's 2.
Second one.
Here's 1. This is 2.
First one.
Here's 1. Here's 2.
I think the first one.
Great. Okay, let's try this one here. This is number 1. This is number 2.
First one.
This is number 1. This is number 2.
Second one.
This is number 1. This is number 2.
I think the first one.
This is number 1. This is number 2.
Second one.
So with temperature sensation, you can see with this tool the metal side is going to be perceived as colder and the plastic side is going to be perceived as warmer. So she has a great perception of temperature discrimination between hot and cold and extremities. They're not as good in her legs, but if you also remember when we checked her temperature of her extremities, they're a little bit colder in her legs than they are in her arm. Meaning her circulation is not as intact in her lower extremity than her upper extremity. So some of that inability to distinguish temperature is really just related to poor circulation, but she was able to clearly distinguish temperatures in both her upper and lower extremity, which lets us know once again her parietal lobe and her peripheral sensory system is intact.
2. 1. 2. 1.
What you don't really see in the video is that I have an instrument that's shaped like an octagon, and then there's like different distances between 2 prongs, 1 millimeter, 2 millimeter, 3 millimeter, 4 millimeters. Just going through and checking her 2-point discrimination. Once again, her 2-point discrimination is intact, meaning her proprioceptors and her extremities and her parietal lobe is functioning normally.
Do you feel that vibrate?
Yes.
Okay, wait, tell me when it stops.
Did.
Okay. You feel it vibrate?
Mm-hmm.
Tell me when it stops.
It did.
You feel it vibrate?
No.
You get a good bone.
Yes.
Tell me when it stops.
It did. Yes.
Tell me when it stops.
It did.
Okay.
Vibration sense evaluation is really important because large diameter fibers are critical for carrying proprioceptive input that helps a person be able to determine from position sense fibers if they're intact and stable. So whenever you see positive Ron-Brooks tests, you should always test the monofilament test and vibration sense to see if those proprioceptive large 1A diameter fibers are working, and with her they are intact.
Go ahead and lay down. And keep your eyes open. Okay, come on up. Any symptoms of that?
Yeah, a little bit dizzy. To the right.
To the right? Okay. You can take those off. Does that help?
Yeah.
You want to stare at something, like stare at that knob. Anytime you get dizzy, I want you to stare at a target.
Something.
Yeah.
Okay. Okay.
You good?
I'm good.
I gotta do the other side.
Okay.
Okay, same kind of thing. You gotta use your feet up. And come on back. Eyes open, eyes open. dizziness?
A little, but not bad.
To the right at the same time? To the right?
No, not kind of like.
To the other side? Okay, you can take these off. And if you go ahead and stare at something.
So here we did the Dix-Hallpike maneuver, and you can see she's wearing these Frenzel goggles where she can't really fixate on a target outward, but I can see her eyes. So with the Dix-Hallpike maneuver, you basically have the patient lie on the table, and then you want to make sure that you have the person head rotated to one side and an extension. And this is a test to see if a person is having benign paroxysmal positional vertigo, BPPV, which is the most common cause of people that have vertigo and dizziness. And typically they'll complain of dizziness and vertigo when they extend their head back and look up, maybe like trying to reach for a cup. They go get their hair cut, they're putting their head into a shampoo bin where their head is extension and rotated, they'll start to have symptoms of dizziness. Those are the typical patterns of BPPV, and this is happening with the otoconii, or having crystals that are then dislodging into the canal, the posterior horizontal canal, and then that'll cause symptoms. And with this test, what you have to see is you have to see nystagmus, and you see this oblique type of nystagmus pattern. But she doesn't have that. Just because she has symptoms of disorientation, that's not a positive Dix-Hallpike maneuver. Dix-Hallpike maneuver, you have to see characteristic nystagmus pattern, and then you would do an Epley maneuver to reposition that. So she's having some difficulties with her vestibular integration or cerebellum. So when she's moving into different positions, she's feeling a little bit disoriented and dizzy. And we know that her VOR cancellation pathway is not working well. So the way you just get rid of that dizziness first is to have her focus on a target, and it seems to work pretty well for her. So this is not a positive Dix-Hallpike maneuver because we didn't actually see nystagmus develop. So this is not due to any kind of dislodged crystals in her inner ear.
And let that rest here. I'm just going to check your heart rate and your pulse ox. Let's use this one. Okay. I want you to take some deep breaths in and out. Okay, and just relax. There we go. That's going up. So it was 92, now it's up to 97%.
What is that?
You're not getting enough. You're not
Oxygen.
getting good respiration.
That's oxygen.
It's oxygen. And it's going to be really hard to get your balance under control unless we get oxygen to your brain.
So as you can see, her saturation of oxygen is pretty low at 92%, 94%. And this is really important because this may indicate that she may have some type of respiratory issue. She may have some kind of vascularization, circulation issue. Make sure that she doesn't have any cardiovascular dysfunction, and or any types of patterns of anemia that may be impacting her oxygen levels. So I have her take some deep breaths in, and as we have her take some deep breaths in, we can see that these numbers start to improve into within a normal reference range. And one of the things about her, she just is very, very frail, and she doesn't have a lot of good deep breaths when you just observe her. So these may look like they're pulmonary disorders. Obviously, we're going to do a pulmonary examination and go through all those steps. She's already had that done extensively in the past, but the new things do show up. But her SpO2 levels are normal. So anytime you see the SpO2 levels, and we'll have people taking deep breaths. If deep breaths are not changing it, then you're more worried about things like anemia and other types of metabolic pathology. But in her case, we're just really seeing that her chest cavity is not moving. Now, when people are in a sympathetic fight or flight mode that's pretty severe, like her pattern of her constant degrees of dizziness, you really sometimes have just suppression of the parasympathetic activity. Remember, deep respiration and really getting that diaphragm activity really involves those parasympathetic responses as well. So those are the key things that are there, and we have to dig a little bit deeper and figure out what's happening with the rest of the exam.
Okay. I just got you in case you're... Are you spinning the left?
Yeah, I'm pretending in my mind, right?
Yes.
Okay.
Okay, go ahead and spin to the right. Okay, and just relax. Okay, so we saw your heart rate raise to the right. And go to the left. Visualize going to the left. And we see a drop. Keep going to the left.
You mean the right?
No, left. I want you to go left.
Okay. That's what I was doing.
Great.
So when you look at the pulse oximeter reading, you can see that the tissue saturation of oxygen is really poor, and she's really not taking normal breath, and her chest cavity isn't moving. But even more importantly is if you look at her heart rate, we have her visualize movement to the left and to the right, and when she visualizes moving to the right, we can definitely see her heart rate go up. So this is a reflection of how much her vestibular system is impacting her autonomic function.
Do you want me to do it again?
We're going to do it one more time. I just want to get your heart rate a little stable.
To the right now or to the left still?
We're going to go to the right.
Okay.
Okay. Go ahead and go to the right. Okay, go ahead and stop.
So whenever you see something that's functionally abnormal, you always want to repeat it, make sure that it wasn't just some random response. So here we had a chance for her to rest in between the previous pulse oximeter testing. We do the test one more time, and once again, she visualizes moving to the right. You can see that heart rate go up.
Going to the right.
And this is a third attempt to really see if this is physiologically happening, and once again, giving her a little rest in between each of these sessions, and then having her visualize moving to the right, and again, heart rate goes up pretty clearly there. So with ophthalmoscopy, you can get a really good indication of vascular health. So remember, she has signs of microvascular disease, and she has signs of nerve inflammation. So when you're really looking at the optic nerve, you're really looking at brain tissue. You're really looking at the cranial nerves that are going from the eye all the way up into the brain. So the optic nerve pathways were healthy. There was no imbalances in her retina, no signs of microvascular disease in her eyes, which was great. So you can see that her blood pressure is normal in a seated position, and then when we have her stand, that we get this drop in blood pressure, this orthostatic hypotension type pattern. And these are not necessarily adrenal issues. These are related to vestibular activation of autonomic centers that cause these types of responses. This is kind of like a cheap version of a POTS test that's really easy to do in your office for really quickly, but you see these with different types of dysautonomia patterns related to vestibular issues.
Yes, you have very good circulation.
Oh, that's good to know, because I always think I don't have very good circulation.
And when we see that low SpO, this oxygen saturation, we're always worried about one of the mechanisms going to be just bad circulation.
Oh.
But your circulation, by looking at temperature, seems pretty good.
Oh, good.
Your feet aren't as good, but your hands are really good.
So you can see with surface temperature of the extremities that it's pretty equal in the upper extremity. In the lower extremity, it's not as ideal. Usually we consider things abnormal if it's more than 10-degree difference between proximal and distal tissues for poor circulation. Now in her hands, everything is fine. And remember that her oxygen saturation was really low. So one of the things you want to rule out is just poor circulation and low blood pressure. And her blood pressure was intact and her circulation is intact. So it doesn't seem like those are factors that are impacting her oxygen saturation. That's most likely just the fact that she's not taking really deep breaths, and we still need to evaluate her pulmonary function to see what's happening there.
So you see we have a little bit of whiteness there. Let me turn it here. Does come back in normal time, just a little bit of whiteness there. Yep. You look at the very tip here, the pink part there. Push down, comes back pretty quick. Great.
So even though the lower parts of her nail bed are a little bit white, the outer edges are pink, and then the capillary refill is intact. One of the things you'll always see with anemia, well, not always, but you can see many times, is you will see that this pallor of the inner eyelids, and hers are very, very red. So we like to see that, and that's pretty healthy.
So I'm just going to palpate your thyroid gland here. Go ahead and swallow. Okay. That's good. You might be able to feel it yourself. It
hurts just a little when you did that.
Yeah, they're just a little sensitive. You feel? You want to put your finger right there? Feel that little BB?
Mm-hmm.
Yep. Okay. Now let me feel your lymph nodes here. Just relax your head a little bit. Yeah. Okay. Yeah, you got a couple swollen right up in here. Let's check your chain here. Okay. Yeah, you got some swollen lymph nodes. Where do you normally feel? You said you feel them yourself too? Do they swell up?
Just like all that you did.
Yeah.
I can even feel this sometimes in my thyroid.
Yeah, you got definitely some swelling there. Okay.
So with thyroid palpation, we can see that she has multiple nodules, and that's not uncommon, especially with age. So 70% of all 70-year-olds are going to have at least one thyroid nodule. She has multiple nodules, and even in some of her medical records in the case review file, you can see that those were identified with ultrasound in the past. So multiple nodules, multinodular patterns is not uncommon to see with Hashimoto's pattern. It's not like it's a very large single nodule that needs to be evaluated, so it's not significant enough for me to be concerned. The other thing is that she's got lymph node swelling all throughout her cervical chain, and this is just part of her chronic immune challenges that she's having. And hopefully over time, as we get her immune system healthier, we should see some of these lymph node swellings improve.
Okay, so you just relax. I'm just going to listen to your.
Okay.
I'm going to listen to your heart first, and then when I listen to your lungs last, take some deep breaths. But for
Okay.
now, just relax. I'm also going to listen to your thyroid real quick. I'm going to listen to your carotid artery. Deep breath. Out. Deep breath. Deep breath. Okay, relax. So now when I place this on you, go ahead and take a deep breath all the way in, all the way out. And here. Okay. A little bit deeper. Let me just move this in here. Out. Good. And deep breaths. I'm going to listen to your heart arteries one more time. This time I'm going to listen to your heart arteries. What I want you to do is I'm going to ask you to hold your breath and bear down. Like that.
Okay.
Okay. But just not yet. I'll let you know.
Okay.
So I'm going to listen to this side. Okay, go ahead and bear down. And relax. And go ahead and bear down. And relax.
Auscultation of her thyroid, which really would only show up any patterns if it's a hyperthyroid response, and then of her carotid arteries, heart, and lungs were all intact. No signs of any abnormalities. She had, a very mild systolic murmur, and then with her lungs, there was no issues with any kind of abnormal wheezing or any types of abnormal breath sounds. She just does not take deep breaths. So you can just see that she's a very, very shallow breather, and she doesn't have much chest expansion. Abdominal auscultation was normal. She had healthy bowel sounds and healthy bowel activity. The frequency of her bowel contractions were normal. And if you look at her symptoms on the metabolic assessment form, she doesn't have any symptoms of gastrointestinal imbalances. So her gut motor function and looks like her gastrointestinal metabolic function is intact.
Not really. I mean, a little bit.
Explain it.
I don't know what's normal, you know what I'm saying? But yeah, a little bit. I don't know.
Okay, but it does feel off to you.
Yeah.
Have you stabilized yet or not?
Oh yeah.
Okay. The other side here. Turn your head like this.
There's nothing there.
Nothing there.
Not really.
No problem. Okay. Let's bring it back up. We're going to do the other side one more time, just to confirm. And turn your head to the right. A little bit more. There we go.
There's just a little bit of something that goes on actually behind my eyes. And I don't know. I don't know. Maybe not.
No problem.
So at the Klein's test, you can see that when we have her head rotated back into extension into the right, she has some symptoms of disorientation. So this may be misinterpreted as a positive test, but the structure of this test is that you're stretching out the vertebral arteries and you're trying to see if there's any kind of symptom development. But with her, we know that just visualizing movement to the right increases her heart rate. When she does any kind of gaze to the right, she gets a right beat nystagmus. So this is more likely just symptoms associated with central vestibular disorder involving her vestibulocerebellar pathways and less likely to be involved with her vertebral arteries. But at some point, looking at her calcium channels, carotid calcium scores, and looking at her vascular integrity may be important.
So we call pendulum reflexes. You can't see how they kind of keep swinging?
They're not supposed to do that?
So when you look at her patellar reflexes, she's got this pattern of pendulum reflexes. So when there is cerebellar dysfunction, there's a pattern of hypotonia. And when there's hypotonia, when you hit a D-tendon reflex and cause that monosynaptic reflex to cause the knee to extend, there isn't any tone to antagonize the weight of the leg coming back. So it just swings further back and then it just starts to swing like a pendulum. So pendulum reflexes are associated with cerebellar dysfunction. As you can see, we already have a positive Romberg test and left beat nystagmus, right beat nystagmus, down beat nystagmus, patterns of ataxia. So we know that it's a finding associated with everything else suggesting cerebellar disease.
So in the summary report I put in, I said there's some concerns you may have some basic ganglia issues associated with Parkinsonism. You don't have any of those patterns. There's a few things we need to check still. But let me ask you a few questions. You said your voice is getting a lot softer. What does that mean to you? Or can you explain it to me more?
I'm tired.
You're just tired. You're just exhausted.
It's harder for me maybe to talk like people talk, but plus it irritates me, right?
It's the noise part of this, yeah.
Right.
Okay.
So I've gotten a lot softer. Not that I ever yelled much.
And days when you have better energy, do you speak differently? Is it louder? Or does that still bother you as well?
I'm not real sure because I don't have days with better energy. I feel bad all all the time.
Okay.
I haven't had a day that I feel.
When was the last good day you had?
It'll be a little over 4 years in January since I got Ramsay Hunt. I have not felt good. There's not been a day where I felt like I used to feel. I'm not, and so, but on the other side of that, there's better days that I feel bad and some days I feel worse. So I take the days that I still feel bad, but they're not as bad as other days.
Okay. I understand. You want tissue? Okay. That's good. Let it out.
One of the symptoms that was clear on the brain region localization form is that she complains that she doesn't have a strong voice. So soft voices or hypophonia is one of the early findings of Parkinsonism. Now, in her case, she has a soft voice, but it's not because of Parkinsonism. She has no signs of Parkinsonism anywhere in her physical exam. But what happens with the cranial nerve 7 lesion is that the cranial nerve 7 also innervates the stapedius muscle. And the stapedius muscle is a muscle that prevents exaggerated vibration of the cochlear ossicles. So when people get cranial nerve 7 injuries, they get this hyperacusis type of pattern where they're extremely sensitive to noise, and in her case, noise is her voice. So she doesn't like to speak loudly because she doesn't have the ability for her cranial nerve 7 to activate the stapedius muscle and decrease the amount of vibration as a modulation of her ability to control the amount of sound that comes into her brain. Now, this is something that you'll see with people that have cranial nerve 7 lesions. And, when people lose their hearing, they just shout. So with her, she just has an extreme sensitivity to sound that's making her not speak very loudly. So it's really important to do spirometry evaluation with her because she has such a poor oxygen saturation. So at this point, we know her spirometry readings are okay, and that her lung sounds are okay, and that she clearly is not taking deep respirations. So we're less concerned about that low SpO2. And when she does take deep breaths in and make some concentrated effort to really expand and breathe in, that we do see her pulse ox go back to a normal state. So these things are important for us to rule out mechanisms that can impact her poor tissue saturation levels measured with a pulse ox. So for the most part, her cardinal fields of gaze are intact, and she doesn't have any types of oculomotor palsies, any patterns that are impacting the strabismus or alignment of her eyeball. If you want to be really critical with some of these movements, there's a little bit of choppy activity. Sometimes you'll see that with midline cerebellar patterns, but it's very minor. So the cover uncover test was normal. There's no patterns of screw deviation. There's no patterns of exoesophoria. And, these are just checking the integrity of cranial nerves 3, 4, and 6. So with this test, the vestibulocular reflexes are being evaluated in a head impulse test. These are just looking at the integrity of the vestibular cerebellum. So you have the patient basically look right between your eyes on a target on your forehead, and then just move the head back and forth. And there should be really clear and smooth movements and no bouncing of the eyes. So there was some slight bouncing of the eyes with those types of movements. And then also with the head impulse test, when you bring the head back quickly, there should be no catching up of the eyes with the head position. And she had a positive test. So these things, once again, clearly indicate that there's some issues happening with the integrity of her cerebellum, especially midline cerebellum.
Are my eyes closed?
Yeah, you have to have your eyes closed. So just say now as soon as you feel it.
Yeah. But it's on the top of my foot, not
Yeah,
the
I'll do
bottom.
both.
Okay. Yes. 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 Yes.
Okay, great.
So once again, with anyone that has any degree of instability issues in Romberg's, you always want to make sure that there's no patterns of peripheral neuropathy. The monofilament test is just a really quick and easy way to rule out any issues with sensory input coming from the feet that may be impacting balances associated with peripheral neuropathy. So our monofilament test findings are all normal.
And just right back a little bit more. Take your tongue out more. Okay, say ah.
So with evaluation of her tonsils and palate, and also saliva production, everything seemed intact with the exception that she doesn't have any tonsils. So her tonsils were removed when she was a child. So we can't see any patterns of tonsil swelling that you might see with a viral response. Her palate moves, and then her mouth is very wet, so she is having activation of saliva production. Remember, the superior salivatory nuclei for cranial nerve 7 is involved with salivary production, but it is in a different location than the motor cranial nerve of 7. The motor cranial nerve 7 is in the mid area of the brainstem. The superior salivatory nuclei is in the lateral areas of the brainstem. So her saliva production is intact, as well as her palate function, which is 9 and 10, and again, no tonsils.
So I'm laying down and like in bed, and if I move my leg the wrong way, my foot will go out and it'll hurt, it'll spasm, right? I get cramps. I guess they're called cramps in my legs.
Yeah.
A lot of times, a lot. And then I've got,
You get some swollen ankles.
I've got swollen ankles
How long have the ankles been swollen for?
a long time before this.
Before?
Mhm.
Let's go take an image of those.
And sometimes I'll get hurt in here, and sometimes I can't walk on this leg very well.
Okay.
Or it'll get red up to here.
Okay. Did it get more swollen than this? Or is this pretty much it?
No, this is pretty much it.
Okay.
So the symptoms that Catherine is talking about are all really associated with chronic venous insufficiency. So with chronic venous insufficiency, you get that swelling of the legs. Common symptoms are usually pain and heaviness in the legs, leg cramps and spasms. And then also with the skin, you can see it start to look really flaky and even a little bit leathery. And then typically aching can get so bad that sometimes they just don't feel like walking. So with venous insufficiency, the valves of the veins are not working very well. So they're not really allowing blood flow to go back to the heart well. Get all that vascular waste and lactate that just irritates the muscles and legs and can cause some significant discomfort. And since the valves aren't working, you get some of that fluid retention in the legs. So we need to do a Doppler to really evaluate this a little bit better, but these are very clear symptoms associated with chronic venous insufficiency, which is further confirmed with her appearance of her swelling and her changes of her skin looking a little bit leathery and a little bit flaky as well.
Sorry. Should we also? So, squeeze your calf. Okay. stretch your leg out. There you go. And bring it down. So this is your, do you hear that?
Well, I hear it. What is it saying to you?
Okay, so when we squeeze your foot this way, we should hear a swish. You hear that swish? That's your blood being pushed down your artery, your veins, okay? Your vasculature. Now if we push here, we shouldn't hear anything.
How come?
Because your valves are really weak.
My bowels?
Your valves.
My bowels.
Your venous valves. That's probably why your leg's getting swollen. Okay? Check the other side here. You gotta get your vascular system a little healthier because you also have some microvascular issues on the MRI, and I'll go over all that with you when we go over all your labs. Just gonna twist this here. That was that side at the end you had some. Okay. No problem.
So you can see examination of her tibial artery and vein with the Doppler really showed that her pattern of venous and valve integrity is compromised. So, when you squeeze the calf muscle, you really shouldn't hear anything in those tibial arteries. But if the valves are not working well, you'll hear that swish sound. It was much worse on the right leg than the left leg. But this further confirms the diagnosis of chronic venous insufficiency. Now, the best thing to do is really compression socks, and then physical exercise and movement, and then natural compounds like butcher's broom, things that increase nitric oxide like vinpocetine, huperzine, maybe some things that we may employ later, but right now we have to get her out of the acute sympathetic response because the fact that she feels like she's falling all the time can increase her heart rate and increase her vascular pressure and make everything much worse. But if you look at her 18 chief complaint symptoms, about 6 of those are related to her leg pain and cramping and inability to walk, and it's pretty clear now after an exam that those are all associated with chronic venous insufficiency.